Recording in progress. Okay. And Manager Kitchen's here, perfect timing. Okay. Good afternoon, everyone. Today is June 14th, 2023, and it is 4:07. As a quorum of the committee is in attendance, I would like to call to order the meeting of the Central Health Budget and Finance Committee. As a reminder, some of our committee members may be also participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. The first item of business is public communication. Members of the public who wish to make comments virtually during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Yesina, did anyone register to make comments for the Budget and Finance Committee?
Madam Chair, we do not have anyone signed up to speak.
Thank you. So we do not have anyone signed up for the Budget and Finance Committee. I just want to make a quick comment. We have not received a lot of communication for the public. If there's a way that we can probably advertise for our meetings in terms just to more outreach for our community. I think it's really important, necessary that we hear their voices. So it's something that we may want to consider moving forward. Thank you. And I'll proceed. So we'll proceed to the committee agenda. Managers, in order to manage our time effectively, committee agenda item number 5 will be heard last, and we may pass on that item if we're pressed on time. So to move forward, I am going to take on agenda item number 1, and that is approve the minutes of the May 24th, 2023 Budget and Finance Committee meeting. Do I have a motion for that? Manager Valadez?
I move that we approve the minutes for the May 24th, 2023 Budget and Finance Committee meeting.
Thank you. Do I have a second?
Second.
Manager Brunson second. So I have a first, a motion by Manager Valadez and a second by Manager Brunson. Any further discussions? All in favor? Any abstentions? I see none. Motion moves. Now we're moving on to agenda item number 2. Discuss and take appropriate action on a resolution of the Board of Managers of the Travis County Healthcare District approving the issuance and the terms and provisions and pricing of the district's certificates of obligations in an amount not to exceed $100,000, approving the form. Did I? 100 million. I'm like the numbers. I'm like, okay. $100 million, approving the form of and requesting that the Travis County Commissioners Court approve and adopt orders to authorize issuance of such certificates and other related matters. For this item, Jeff Canodal and Lisa Owens will be presenting. Thank you.
Thank you. Jeff Canodal, CFO. I want to go through this item fairly quick. We're winding down on the process. This is an item, you'll go to the next slide, to see if I can get this right, to request recommendation from the Budget Finance Committee to the Central Health Board of Managers to request approval from the Board of Managers to the Travis County Commissioners to issue certificates of obligation in an amount not to exceed $100 million and to delegate authority to the Central Health President and CFO to execute the sale within 360 days of approval. So this is known as a delegated sale. Next slide. So there are two series in the request. The first series is a what's called tax exempt series. It's for the renovation of Rosewood, Zaragoza, our multi-specialty clinic. Just as a reminder, it's a facility that the city of Austin owns. Central Health is in a long-term lease for the facility and is in the process of extending the lease. to a minimum of up to 2044. This particular series would be a 10-year series in the amount of $10 million. And then the second series is what's called a taxable series. It's for the purchase and renovation of the Cameron Center, and we'll go through a little bit of detail on that property. Next. So, as it relates to Rosewood Zaragoza, there are 6 planned specialties to be performed. You see them listed in this slide with some of the estimated volumes that will occur in the upcoming year. The specialties that will be provided upon the opening will be pulmonology, cardiology, gastroenterology, podiatry, neurology, and nephrology. Next slide. This is an aerial of the Cameron Center. There are 3 buildings on the property. Central Health has already purchased the property and is in the process of doing the planning related to the renovations. And you see the buildings and the square footages of each of the buildings on the campus, and the services that would be provided in these facilities. Next slide. So with the issuance of this debt, the taxpayer impact using fiscal year 23 numbers and calculating what the new debt service rate would be and what the taxpayer impact would be on the average homestead is down on the right. There's a lot of calculations here. You see the Cameron Center difference is a little over $11, and then the Rosewood Zaragoza improvements are $1.73 for an aggregate impact of $12.84. And then at the bottom is just, again, a kind of a benchmark comparison of other hospital districts with Travis County and our per capita debt. Next slide. So key dates and key events. In March, the approval of the intent to issue the contractual obligations was approved by both Central Health and the Travis County Commissioners. That began a process of public notice. The public notices were run in the appropriate publications. We are in the process of receiving our bond ratings. We're seeking ratings from 2 agencies, Moody's and a new rating agency called Kroll Ratings. We don't have those ratings, but we expect to go to the Travis County Commissioners Court on the 27th of June, and so we think we'll have received those ratings hopefully by the 20th, but before the meeting. And then last but not least, upon approval would be the actual sale of the contractual obligations, and again, that's a delegated authority to the CEO and CFO of Central Health up to 360 days of the approval. Next slide. And again, just a reiteration of the requested action to approve the resolution for the Board of Managers for the issuance of the certificates of obligation. I probably should mention on the delegation of sale that we have a number of professionals that do this all the time, that work with us. Our financial advisors, Public Finance Management, or PFM, are the Central Health, both Central Health and Travis County's financial advisors, and then we have bond counsel that works specifically with us to ensure that we are in compliance with all the regulations associated with issuing the contractual obligations. So with that, I'll turn it back over, and if there are any questions, be more than happy to answer.
Thank you so much, appreciate it. Before we start, can I entertain a motion by Manager McWarney?
I move that the Budget and Finance Committee recommend the Board of Managers adopt the resolution approving the issuance of certificates of obligation in an amount not to exceed $100 million and request that the Travis County Commissioners Court approve and adopt orders to authorize the issuance of the certificates.
Thank you. I have a motion. Can I have a second? Yes, Manager Kitchen? We'll have a discussion once I have the second. Can I have a second?
I'll go ahead.
Manager Valdez, so I have a motion and a second. Any discussions? Manager Kitchen?
I just want to confirm, I see it on the slide, the planned healthcare services. I see the medical respite and the associated services like mental and behavioral health services, case management, SDOH resources, housing connections, that sort of thing. So I see that there. I just want to confirm again that the language that we're issuing under is the language here on this slide for Cameron Center. And it says medical, clinical, and district services. So I'm just confirming that when we say those words, medical, clinical, and district services, we're talking about this list of services right here, and there's no concern that it's too narrow, or that it'll be called too narrow in the future. I guess that's more of a, I don't know if that's a question for you.
We run that through our bond council.
Okay,
But we did not get a request to change any of the language. I think there might be somebody on from ORIC if they want to respond to that.
Do we have anyone from ORIC?
Is Taylor or Jerry Call on? Could they speak to that question?
Yes, I'm sorry. Jerry Kyle's on and Taylor's on as well. Can y'all hear me okay?
Yes.
Yes, thank you.
Hey, thank you. And I apologize for dialing remotely. But yes, in response to the question.
Jerry, sorry, this is David Duncan. Jerry, can you turn your video on if possible?
Yes, sorry. Is that okay?
Yes, thank you.
Can you hear me? And I apologize. I'm traveling on the right now, so I apologize for dialing in remotely. But yes, in response to the question, the statement of purpose, we're comfortable that it encompasses the proposed project. It's very broad and general to encompass what's being proposed for this financing.
okay.
Thank you.
All right, thank you very much.
Any further questions? Does that answer your question, Manager?
Yeah, I just wanted to avoid concern, in a year or two or three or four that medical respite's not covered by medical, clinical, and district services. But I'm hearing an affirmation that it is from our bond council, so that's why I'm good.
Great, thank you. Manager Valdez?
Thank you very much.
Thank you.
Thank you, sir.
And with respect to district services, what exactly are we talking about? Are they going to be medical services? I know you say medical, you say clinical, but district services, are we talking about something other than provision of, I'm talking, I guess what I want to know clearly is whether we're throwing into the mix social determinants of health issues, housing, access to housing, things like that. Because I've had a conversation, I think just a brief conversation with Mike, and I don't have a problem with our navigators communicating and referring our patients to places where they will be able to be safe and access something that will help them increase their quality of life while they're under our care or the care of physicians or medical or hospital or clinical services for the district. But anything else, like if it's going to be oh, we're gonna pay for some housing costs, we're gonna pay for this, we're gonna pay for that. I think that should come from the entities that were created or responsible for providing that. So I just want to be clear that that is not going to be included in these, expenditures.
So, first part of your question, completely agree with what you're saying, that statutorily, it's related to what we can actually pay for and does not include, the areas you mentioned, housing. It does not include it. It's clinical services and respite.
And I'm assuming that would include the pharmacy, the drugs, and whatever else. Is that correct?
Any clinical services, yes.
Okay,
Thank you. Does that answer your question?
I believe so. If he's telling me definitively yes, that, I mean, that I'm correct and that it is not going to cover those services.
It is not covering housing.
No, it's not only housing. It's anything other than the medical, clinical, hospital services.
Services,
Whatever is considered
medical,
clinical will be
right.
covered.
Right, under the terms of our
Right.
281. Thank you.
Correct. Manager Kitchen, you had something you wanted? And I'll take you, Manager Jones, after.
I think my question was answered. It's anything that we're legally able to provide.
Okay, thank you.
that's correct.
Manager Jones,
Yeah, just for full disclosure.
your microphone, please.
Over on page 21, you referenced the Texas Hospital District per capita long-term debt, and you've listed them by counties. I want to make sure that this refers to the significant difference between Travis and Harris and Dallas is due primarily to the operation of a hospital.
Yes, that would be the difference, and I would actually go a step further and say that Terrence in the midst of a new hospital construction, so at some point in a year or two, their amount will be significantly higher, and then Harris is evaluating that also. But yes, to your point, that's the difference between Travis and the other districts is the operation of a hospital.
And I think it's important for the public to understand that when we talk, because a lot of time we do put out the numbers of how low we are in terms of debt, but that's important for them to know. And I don't know if you can answer this question or anyone else, but I understand Natchez County was considering a model similar to Travis. Does anyone know if Corpus Christi went ahead with that model for more of a financing as opposed to service?
I'm not sure what they're considering, but their model is different than owning and operating a hospital, but it's different than what it is here too. It's more of participation in the governance of the hospital is kind of their model.
Okay, because as Texas grows rapidly, we look at the urban centers around the state, these models become important for people to understand why this versus that, and I just want to emphasize that at this point. That's it, thank you.
Thank you, Manager Jones. Any further questions? Let me,
Oh, no,
Just
this
ask
is
if there's
just a
any-
follow-up.
is it a quick follow-up,
It's
Manager?
a quick follow-up to.
Yes, go ahead,
To Shannon
Valdez.
Jones, Manager Jones's question. Jeff, is there a way for us to put, maybe a disclaimer under here that says that Travis County does not participate in a similar way or something so that they will know, the public will know that there is a difference in what we provide and what the other hospital districts are actually doing in the model.
So, if I understand you correctly, you just want that distinction that Central Health does not own a hospital, others do.
Yeah, we
We can-
typically have that, and
Yeah.
most, it just, that part of it got left off. And the other part of it, just to be clear, is it's not only capital debt, but some of the hospital districts also have pension debt, and so that's part of the long-term debt also. So I just wanted to make sure it's not just associated with the hospital. There are some other pieces that are included in long-term debt.
And we've been typically including that
Yes.
distinction in our slides for transparency's sake. So we've been doing that, and I thank Manager Jones for always emphasizing that distinction. Any further questions on this item? I see none, so I have a motion by Manager Motwani, a second by Manager Valadez. All in favor? Any abstentions? I see none, so motion moves. Thank you so much. Oh, sorry, I cannot, is Dr. Bell with us? I am so sorry, I apologize. I just can't see you. Can you keep him before us? Make sure, thank you, you're present. So you're in favor, correct, Dr. Bell? Yes, thank you.
Yes.
So the motion moves unanimously, thank you. Now, moving on to our second agenda item. And actually third agenda item, and that is discuss and take appropriate action on setting the central health tax rate 2023 homestead property tax exemption for Travis County residents who are over 65 years or older, or disabled. My apologies. Lisa Owens and Kim Johnson will be presenting. Thank you for being here this evening.
Thank you, Lisa Owens, Deputy CFO. I'm pleased to introduce Kim Johnson, our Budget and Financial Analyst.
Welcome.
This is the kickoff of the budget process, and so you will be getting to know Kim very well over the next few months as we present components of our budget. And I'm going to turn it over to you to give the short presentation.
Thank you, Lisa. It's nice to be here, finally presenting in front of you all. So what we're presenting today is the proposed homestead exemption for the fiscal year 2024 season. Last year, we set the homestead exemption at $110,000, which was aligned with Travis County. And we have gone through a similar process to opt to increase the homestead and disability exemption from that $110,000 to $121,000. Next slide. We basically look at a 3-year rolling average of the increase in the taxable values throughout Travis County, and then look at that percentage and apply it to the actual exemption rate, and so that gets us to $121,000. That is consistent also with what Travis County is proposing as well. And so staff requests that the Central Health Board approve the recommendation to the Travis County Commissioners Court to increase the over 65 and disabled exemptions from $110,000 to $121,000 and maintain the homestead exemption, which is currently at the maximum allowable 20%.
Thank you so much, appreciate that. Before we take any discussion, can I have a motion, Manager Jones?
I move that the Budget and Finance Committee recommends to the Board of Managers request that the Travis County Commissioners Court approve homestead property tax exemption for Travis County residents who are 65 and older or disabled for the 2023 tax year of $121,000 as recommended by staff.
Thank you so much. Can I have a second? Manager Motwani?
A second.
Thank you. So I have a motion by Manager Jones, a second by Manager Motwani. Any discussions? Manager Valadez?
Yes, I'd like to know whether or not we have, Jeff, or Lisa, whether or not y'all have factored in the possibility that we could also extend an exemption to veterans in Travis County.
I will follow up with you about that.
Well, the only reason I'm saying that is because if that is possible, then do we need to have a separate motion for that, or can we include veterans in this?
Can't do that. I don't think we can do that.
So the disabled does include disabled veterans. It does include
Right.
disabled
No,
veterans.
it also includes.
But I will follow up with you about the possibility of just veterans. There is, I believe, a state exemption.
Yes, I
And
thought
I'll
that there was
circle
something
back.
at the state level,
Yes.
but I wanted to know whether or not Central Health could incorporate something like that, similar language.
Okay,
Yeah, I don't think so.
I can follow up with you about
And, is that something that we would be able to come back and, before the
I don't believe we would be able
property
to
appraisal?
accomplish that by June 30th, which is when we need to get through. But I'm happy to get back to you.
Well, if it's not going to be able, if we can't do it by before, do we not have a meeting at the end of the month, like the 28th or the 20th? The reason I'm saying, if we don't, then, could I make a motion to include veterans?
Well,
I think I can make a motion. I don't have to have a second, but, I mean, it won't go
I would
anywhere.
not-
But I just wanted to know whether or not that's a possibility.
I definitely support veterans. I have worked with them. I have the utmost respect for them all. At this moment, without consulting with our legal and what we can do, I cannot entertain a motion to add that. Manager Kitchen.
I don't believe that it's allowed. I don't think, the exemption, these exemptions are set by state law, and I don't believe that a separate exemption for veterans exist. I'm not gonna do a legal opinion here, but that's our lawyers. But in the bodies that I've been involved with, it's only the ones that we have here, and of course, veterans if they're disabled. So I don't think it's allowed.
I'd like for clarification, and if nothing else, ask the Attorney General whether or not we can do that, because that's what I would want to do.
So,
Manager Kitchen
our
is-
legal, can you please
Yes,
entertain?
Manager Kitchen is correct. You can only create exemptions that are in Chapter 11 of the tax code. There's homestead,
Yes,
over 65 and disabled, and then there's disabled veteran. And the disabled veteran tax is set at the state. You don't have to set it. It is set where it's set. And it says they are entitled to, and then there's also a subcategory of that, and it varies. The exemption varies depending on the disability rating. 30, 50, and 70 are the three disability ratings. And then there's a special one for over 65 and a disability rating of at least 10%, totally blind in one or both eyes, and then loss of use of one or more limbs. That's a separate category. So there's 4 different categories, but they're all set in state law, and they just are. You don't have to do anything. And there's not one just for veterans. You can't just create, you couldn't create one for, physicians and say all physicians get it, because we want to include, or teachers. There's actually been talk of creating a special one for teachers that was discussed in the legislature. But you can't, the legislature would need to do that and put that in Chapter 11 of the tax code.
Thank you, Mr. Duncan, for that. I appreciate it. Manager Valdez, does that answer your
yes,
concern?
that clearly does, and if Mr. Duncan could please send me a copy of that, I'd appreciate it. And thank you very much, Manager Keith.
Thank you. Can I take Manager Martin? I have not heard from him today.
Thank you.
Thank you.
This is just an educational point for me. So you said the homestead exemption is currently the maximum allowed by law in terms of dollar number
It's a percentage.
as a percentage, irrespective of home value increases. Okay, thank you.
Thank you, Manager Kitchen.
Okay, so just a quick question. So we're saying Travis County is 121, is that right? Did I hear that right?
Travis County is, for the next tax year, is going to the Commissioner's Court in the same process.
Yeah.
To go to 121, as we understand it.
The city just passed theirs, and theirs is 124.
Okay.
What the city has typically done is, I understand the 10% methodology. One of the things the city has typically done, and I don't know if they did it this time, but what they typically do is try to keep people, hold them harmless, so to speak. So they look at things like inflation and stuff like that. So I know we're only talking about a $3,000 difference, but, and I hate to disrupt the meeting, but I would prefer 124,000 because that's where most people live, is in the city. So.
Thank you for that. I just want to make sure, we typically align ourselves with the county. So if we wanted to align ourselves with the city, is that our prerogative? And what's your legal aspect if you wanted to change that? And what's the financial impact?
It is just a recommendation. staff recommendation, we do look 3 years back. So that helps, we thought, smoothing with the
Yeah,
anomaly
that's
of like
fine.
some increase. And the 3-year look back was 10% this past 3 years. So that's what it's based on. That is, I think, trying to accomplish the same thing.
Okay.
Just landing on a slightly different number. So
Okay.
we are trying to accomplish the keeping up with the rising prices, to your point of trying to ease that burden at the same rate, but we do use that 3-year look back.
So the county hasn't set theirs yet, right?
No, I believe it's going to the commissioners on the 20th.
So
or
we
the
could
27th.
recommend 124, which is what the city just voted to set theirs at. So just a thought.
Thank you for that, Manager Martin.
I guess that gets back to my question. I thought there was a maximum rate.
Sorry, we're
Yep.
speaking about disabled
Yeah,
and over
65.
65.
Right, exactly.
There is a third exemption for all.
Yeah, for everyone.
For everyone who has a homestead,
Okay, and that's just period.
yes.
Okay, thank you.
Thank you. Manager Valdez?
Yes, I'd like to know whether or not, the maker of the motion would allow, modification to go to 124,000. And the second, see if they would approve that.
I'd rely on the staff recommendation. The staff recommends it.
I think I made that motion.
You seconded. Yes, that's,
Sorry about that.
no, thank you. Appreciate it.
I don't know, I have to think about that.
Well,
No, I'm being facetious. Yes, I would be very supportive of it.
well then,
The second, I don't know, the second.
no, I'll
So,
second yours.
can I pause for a second, head back to legal, so we can make that adjustment? And I just want to make sure beforehand that I consult with our staff, because it was a staff recommendation. So go ahead, the floor is
Yeah,
yours,
so
Mr.
first of all,
Knoto.
thanks, I'll be quick. So first of all, the setting of the exemptions is through the Travis County Commissioners Court. So we're making a recommendation, and we can make a recommendation to them that they have final authority. So I think what Lisa's describing is we just have a prescribed process that we go through. It's consistent with the counties. We maintain consistent amounts, but there's nothing that inhibits us making a different recommendation. I just wanted the board to understand that, or the committee to understand that the final say is with the commissioners. So
Okay, that's not a no.
that's
just-
not a no. It's
Correct.
Ultimately, the commissioners court will vote and approve the exemption amounts.
So we could go to the commissioner's court also, as individuals, and
Well-
ask them to increase
Let's,
theirs to 124.
Manager I'm sorry, Mr. Giesler.
Thanks for the promotion, appreciate it. Yes, anybody can speak to the Commissioners Court, but under Section 8 of the bylaws, the majority of the board speaks for the recommendation made by the board. And so you will still need to decide, do you want to go with what's been recommended here, or do you want to amend the motion and have it affirmed? Because we need something that has a majority of the board sitting behind it to be able to take to the Commissioners Court that this has been ratified by a majority. Doesn't preclude any of you from going and speaking, as individuals, but you're not speaking in lieu of a board majority. That's all. Thank you.
So what we're speaking right now is about $3,000, correct? So it's nothing, I think, significant. Well, it will definitely help and assist others. I just want to be mindful of it. So in just terms of impact, it's not,
So can I just?
Yes.
run that for you real quick? So it's $3,000, and so divide that by 100, right? So that's 30, and then our tax rate's 10 cents. So we're talking about a difference of $3 between 121 and 124,000.
okay. So, Manager Jones, you have your,
Yeah, I just want to ask, I seconded and I agree with that, I'm supporting it. But to be consistent, this is Travis County utilizing a model that the city of Austin is doing, just for the purpose of discussion here. What does that mean, if anything, as we look to other cities within Travis County who have their own tax rate? I know we're talking about you know, many schools, the mark more goes to the philosophy of what we're doing and why we're doing it, as opposed to the amount. We're setting a precedent by doing this, I think. So that's what I'm trying to get at.
So, so it's a model that the county and Central Health have collaborated on, and agreed to. The city has their own, the city of Boston has its own process. I think Manager Kitchens alluded to as much that I know about it, which is they try to keep the taxpayers that qualify somewhat tax neutral. Again, that's our intent also.
I don't know if the 124 was arrived at that way. I just know the philosophy that I was engaged in previously and I continue to hold is that seniors need this exemption. And that's why I understand it's an impact, of course, and we have to balance that. But I prefer to make it as high as reasonably possible.
Okay,
And that's where I'm at.
thank you. Manager Martin.
Let's have a comment about that, perhaps an opinion. I think that since we are a county service, if we raise our exemption higher and higher and higher, I don't know that we'll be seen as contributing fairly into the system that covers the entire county. We're not just a city entity. And I think to adjust our tax exemption based on a city thing, I think could come across as not particularly fair to other cities if we're increasing the exemption.
Thank you, I appreciate that. So, quickly, Manager Valadez.
Yes. Because we are a county serving entity and because we are facing such economic hardships every day, every week, every month, even a $3,000 increase, that was going to benefit everybody who lives in Travis County, not just the city. She was just citing that number because the city chose to go 124,000. And I personally would like to think that the county commissioners would be amenable to following an example of 124,000 because it would impact everybody, regardless of what city you lived in or village or whatever you lived in Travis County. It would affect every Travis County resident. And let me tell you, people are hurting whether they live in a municipality or outside of jurisdiction and in the county area. People are hurting. We are all hurting. And I am hurting, so I feel the concert, the emotion and the compassion for our population, especially those living under 200% FPL. And if it was going to ultimately end up being a $3 tax increase, and I would think, or maybe $3.10, I would think that that's negligible when we look at what is going to be having to be paid out of someone's, if they've already, I'm looking at the people of this neighborhood, people had already paid their houses off. It had got gentrified and they lost their homes. And so even a credit of $3,000 additional dollars towards their taxes is significant in many households. That's the only reason I appreciated Manager Kitchen's comments. I really appreciated Manager Jones' agreement to increase it. And if he needs another second, then I will second it.
Thank you, I appreciate, and I concur with what you have said. Let me do this, just to make sure. Initially, we had a motion and a second. Let's take a vote on that.
No, you can't do that.
The motion to amend.
It's the other way.
Who withdrew that motion? I'm sorry, I'm missing.
That's a substitute. This is one or two things. It's either a substitute motion or it's a motion remade with an amendment.
So I'm referring to our original motion.
That's the last thing you vote on.
It gets voted on second. She's absolutely right. That's Robert.
That's the last thing you vote on. The first thing you vote on is the amendment or the substitute.
That's correct.
So a motion to amend is a
So the amendment, so Manager Jones, can you amend your motion? What was your amendment to that one?
Everything here other than it's 124.
Okay, so
I second that.
So we have an amended motion and a second. Are we all in favor of that amended motion of 124,000? tax exempt for the,
Recommended.
that is recommended for the 65 years and older and the disabled Travis County residents, correct? So that was what we have on the floor. Are we all in favor?
Yep.
Just one
Yes.
question, I don't want to belabor it too long.
Please.
Commensurate with what we've said, if we're following the city of Austin's model and we're going to 124, in doing so, would this in any of the other municipalities within Travis County that have, let's say, a lower rate, would we be putting them in jeopardy in terms of having to pay more or not penalized? So there's no other municipalities in Travis County that would be impacted in a negative method consistent with what we're doing.
So first of all, we
The
don't,
model, I'm talking about the model, not so much.
we don't follow the city's model. We're only talking about the amount. We're simply requesting to add an additional $3,000 to it. So there's not any I'm not sure I completely understand your question, but there's really no taxpayer impact from other Travis County residents or Central Health taxpayers that live in other cities. The tax calculations are what they are in those municipalities.
Okay, all right then, all right, I'll take your word that, I just want to make sure that was voiced during this process.
Perfect. So this will not have any further impact on individuals. Is that the concern that you had, correct?
Yes.
So we received a confirmation it does not. So I have a motion and a second. All in favor?
This is increasing the homestead exemption to 124 instead of 121.
So Manager Bell, are you in favor of this motion?
No.
Okay, thank you. And Manager Matwani, do you, sorry, you had your, sorry, Manager Martin, so you're not in favor of this one?
I'm not in favor.
So, how many do we have?
Passes.
So the motion carries.
Okay.
Thank you. So that is our recommendation for this. Appreciate it. Sorry, it was just a little confusing on, sometimes when we have an amended motion on the fly, I'm just making sure that it's legally compliant and there's not significant impact.
I want to thank Manager Kitchen for
Clarify, you voted yes, right?
Yes.
Okay, sorry, we're just keeping records here.
Yeah, and I apologize for not bringing it up earlier. It just makes sense to me, so I wanted to give people the opportunity to talk about it.
Thank you. Now, moving along to agenda item number 5. Actually, number 6, sorry. Where am I following?
We just did 3,
Sorry,
and
got
what
it.
about 4?
Oh, I don't know, because it's not numbered here. So, agenda item number 4, discuss and take appropriate action on an agreement with JP Morgan Chase for depository services adapted from the Travis County Depository Services contract through an interlocal agreement. Lisa Owens will be presenting.
Thank you. This was documented in the agenda request. This is simply asking the board to delegate to the president and CEO the authority to execute a depository services agreement when it is adopted by the county. And as outlined in the documents, under Chapter 281, we have the ability to use Travis County's depository services agreement. And we do that through our interlocal with our Chief Investment Officer, Debbie Laudermilk, and we have been working in that manner for many years. So simply a request to delegate to Mike that contract be authorized when it is finalized.
Thank you, Lisa, appreciate it. Manager Valdez, can you please entertain that motion
Yes.
before I take discussion?
I move that the Budget and Finance Committee recommend that the Board of Managers delegate to the President and CEO execution of a contract with JP Morgan Chase for depository services through adoption of the Travis County Depository Services contract with amendments as necessary.
I have a motion by Manager Valdez. Do I have a second? Manager Brunson seconds this motion. Do I have any discussions on this item? So we're just simply following through what the county has vetted the process. So do we have, yes, Manager
Just a
Jones?
question, is this a historical, is this has historical?
Relationship? Yes. Yes, we entered into, the county entered into a contract with JP Morgan in 2017, and we also have been in a contract with them since 2017. And the contract is renewing after the county pursued a solicitation, and JP Morgan was selected.
I mean, is there any competition or any opportunity to consider another one?
David?
There was at the county. There's a very specific process that's set out in state statute for counties to select their depository. It involves vendors sending a bid and sending checks for, it's good faith checks, I believe they're called. And then the county evaluates the proposals, selects a vendor. And they selected JP Morgan Chase in this case. So there was competition, but we're allowed to just adopt their contract. And
Could we have not adopted
we
that?
can do our own separate, it's a very arcane process, I will tell you.
Well, I'm not
It takes a
recommending,
long
I just
time.
wanted to make sure I'm aware.
Yeah, thank you so much for that clarification. Any further, Manager Kitchen?
Just a question, are the terms the same are the terms the same as the terms that we've been living under now?
I have not seen the contract yet,
The
however.
contract has not been executed yet.
Correct. I have been working, the county has their own lawyers working with Ms.
Okay.
Lardell. And I have been speaking with them as they've been going through the process, and we expect that it will be largely very much the same contract that we've had before. Oh, Debbie's here.
And Debbie Laudermilk, our Chief Investment Officer, is here. I'm happy to.
Hi.
Hello, welcome.
Yes, the contract has been negotiated with the county and JP Morgan Chase. There was one other person that sent an application in, that was Frost. The Frost fees were at least 20% higher than what Chase provided us with.
Okay.
So that's why we went with Chase. I believe that the fees that we will be paying, this is based on Travis County, but it goes to you guys too, will be maybe 5% higher at the most for this contract. The contract for Travis County goes to court on Tuesday and will be approved, and I'm actually working on adapting it for Central Health.
Thank you so much for that. Appreciate it. So, do we have any further questions on this item?
I have one follow-up.
Yes, is that?
So I just wanted to understand then, so, because we have and I apologize, I just want to make sure I'm understanding. So we have an existing relationship with JP Morgan, right?
Yes.
Okay.
The depository contract for the last 15 years has been with Chase. There's been banks that have applied, but
Okay.
they've never been able to meet the same costs that Chase has.
Okay. And we're switching the
No, we're
deposit?
not.
No, we're still.
No, we're not switching. It's still Chase.
Yeah.
The contract has a 6-year
Oh,
term.
I'm sorry, of
That's all
course,
right.
of course.
The contract has a 6-year term, and they
So
have the-
we're keeping the same,
Yes.
on the same
Yes,
terms?
except there's better terms.
Okay, all right, I
It's
got
just
it,
the same bank.
I got it.
Thank you. Appreciate it. So, we have a motion by Manager Valdez, a second by Manager Brunson. All in favor?
Aye.
Any opposed? Manager Bell? I didn't.
Aye.
Aye, thank you. So the motion carries. Thank you. Now, moving on to item number 6. Receive updates on the preliminary April 2023 financial statements, including capital projects for Central Health and the Community Care Collaborative. Lisa Owens and Patty Bethke will be presenting. I just
Sure.
wanted, sorry, just to give people, just to really run through why we're, what you're gonna be presenting. So you will be seeing a new, how are we gonna say it? A new format displaying for our financials in the next coming months. So we're just going to walk through simply the new edits and changes.
Sure, it's the same reports, and you'll see in the packet they look similar. However, we are developing those reports. As we've been reporting out, the finance team has switched accounting software. A Herculean effort to the finance team. I want to recognize Patty and her team. Now that we are live, we are able to write all the reports that we need to do. What's included in your backup today is a balance sheet and a sources and uses. And what will be forthcoming at our later meetings this year is all the identified supplemental reporting that the board has asked for in the past, such as details on specialty care. I'm happy to answer any questions. There have been no significant transactions this month. Our tax collection has continued to come in a little bit, and our tobacco settlement funds came in, as we reported last month, a little bit over budget, but otherwise our operational expenditures and our clinical services expenditures to continue at a very similar rate as past months.
Thank you so much, appreciate that. So we just wanted just a brief update on this item. If there's not anything outstanding questions, we can just proceed with our packed agenda. If we needed any follow-up questions, we can reach out to Lisa and her team. Is that fine with everyone? Thank you. Thank you so much, appreciate it. Now moving on to item number 7, receive and discuss the quarterly financial and operational reports for community care, health centers, and Sendero health plans. At this moment, we will have Perla Cabasas and Dr. Mary Carol Jennings will be presenting for Sendero. And then we'll take on community care. So members, we're gonna allow them to present. And if there's any burning questions that needs to be answered while they're up here, we will take it upon. If not, we'll allow community care to present, and then we'll take all questions all at once. Thank you.
Both of those mics will really get away from the table mic and then use the
Okay. Thank you.
My apologies, Perla, you have another
Yes.
member who's not.
Yes.
Can you introduce herself?
I also wanted to introduce Allegra Hastings-Martinez, our Director
Welcome.
of Quality and Population Health Program. We'll be presenting with Dr. Jennings and I. Managers, we submitted our Q1 report for Sendero Health Plans. It's in your board packet. I think we covered most of the items in the template. A lot of this is, I think, self-explanatory. I'm open to questions. There's a financial also update in there for Q1. But what I wanted to focus our limited time on today was significant accomplishment for Q1, which was the completion of our first inaugural in-house population health assessment report. This was the 137-page report that we shared with you, but knowing that you probably didn't have time to get through all of it, we have prepared a brief slide deck today that will focus on highlights of the report. And just, I think this is very interesting, and we've tried to, it gives you I know you all are interested in the demographics and utilization of services of our members, and specifically the CHAP expansion population, which are former members. And so the few slides that we want to zoom through today are going to be focused on quality initiatives, and then some just some highlights of that report. I'll leave it at that. So I'm going to kick it off to Allegra.
Hello, everyone. So last year we had research consultant that helped us develop some of these documents around all of our different quality initiatives. So they cover 3 different cancer screenings. There was an overall passport to health that was developed for our members, diabetic member education specific booklets, and then a sweepstakes campaign that was developed last year that we are continuing for this year. So these are just some examples of the cancer screening postcards that we are sending out to our members this year. There's one specifically for cervical cancer, for breast cancer, and for colorectal cancer. All of these different screening initiatives have $25 to $50 incentives tied to them for our members, so that our members not only get the cancer screenings that they need, but they're also incentivized with a gift card to hopefully push them to get those screenings and get that invasive colonoscopy. Next, these are examples of the passport to health documents that were developed. These are age and sex specific booklets that are sent out to our members. So there are specific booklets with recommended screenings sent to all of our adult population. Women under 50 have their own booklet, men under 50 have their own booklet, women over 50 have their own, and men over 50 have their own, with recommended screenings, vaccinations, and overall health education for our members by age and sex. And then last of my slides is an example of our diabetes booklet that's sent out to our diabetic members specifically. It's both educational and a tracking tool that our members can use to track their A1Cs, make sure that they schedule their kidney screenings with their PCPs or their nephrologists, and making sure that they get their diabetic medical eye exams to prevent blindness. And then the last thing that I have to present today is our Golden Ticket Sweepstakes that was started last year, the first year. So for all of the members who are in our diabetic population, our cervical cancer, colorectal cancer, and breast cancer populations, all 4 of those different populations have a sweepstakes tied to them. So if they get their screenings, their mammograms, their pap smears, their colonoscopies, their medical eye exams, they will be entered in to win a $1,000 gift card at the end of the year. So in addition to the incentives that we're giving them to get those screenings, they are entered into the sweepstakes at the end of the year to incentivize them to get the screenings, but also to have a little holiday present at the end of the year that might benefit some of our members. And with that, I'll give it over to Dr. Jennings if no one has questions.
All of those materials are available or sent out in Spanish as well. Spanish is the most common language that our members speak, and that was just kind of the tip of the iceberg, focusing on some member-facing programs that we run. Next we'll focus on the population assessment. Do I need to hold this? Yes. Yes. No. Thanks. Okay, on the population assessment, which is the 60-page document in your binders. A brief note on context. So this is the inaugural in-house report. We've been doing this since we've been accredited with NCQA with an external vendor, and we brought it in-house this year. The data sources are plan year 2021 data and the 2 years before that, so it's usually a 3-year report drawn from our data warehouse and supplemented with population level data where appropriate. It's developed annually for our health plan quality accreditation purposes. That's the National Committee for Quality Assurance, and it adheres to many of the definitions are determined by the NCQA's standards and guidelines. And the main role of this report, it's an internal report. We build it out for ourselves, but we're excited about it and wanted to share it with you. It informs internal resource planning, such as staffing, training, new programs, case finding strategy, etc. A couple notes on what it does provide are insightful, high-level trend information and direction for a deeper dive analysis, but it doesn't provide that kind of detailed deep dive information on why we see a trend or on individual patient experiences. So we start, you can follow along with me on page 7 if you'd like, but we start this report with some demographics and social determinants information. And from this table on page 7, I think the highlights here are in plan year 2021, Sendero supported a primarily adult population. 4% were over 65, 11% were children, and 65% of members resided in Travis. Of course, all of CHAF expansion program members reside in Travis. We take this report and we segment our whole population into different segments based on disease burden or programs that we run or things that will help us improve our programs. So it's some of these populations are just prescribed by NCQA and some are selected by the plan. And here we've got the all population, which you see throughout the different tables. That's just all of our membership for a given plan year. And it includes each of the other segments that we've created for the report to inform our thinking. I will focus on observations, as Perla mentioned, for the CHAP expansion population in comparison with a few others. And then just to note, you see here, the proportion of the CHAP expansion population has increased from 1 to 3 to 7% over time. And we attribute that, we've just been partnered with Central Health to increase that program membership over time. The notable trend is an increasing number of re-enrollees in each year as the program continues. And so on page 11, screening and screening and referral to our internal team or external resources are a core pillar of our case management program, of any case management program. And at present, our case management staff manually track these numbers. However, we're evaluating other case management software programs to allow more functional reporting of that data and other related data. For this report, we've pulled out the segment of members experiencing limited access to reliable transportation. I'm really proud of the work our case management team has done over the past years to build out a robust transportation program that provides Lyft and a medical transport ride through a vendor to alleviate limited access to transportation as a barrier to care. So we're going to highlight 4 different utilization metrics, and I'll walk you through that in the next 4 or 5 slides. We've used this population assessment to build out reporting on really these common metrics that are core for a health plan to be tracking to understand its population. So first of all, we'll look at acute care facility admissions, and these are given as rates per 1,000 members per year. The facilities included in this metric are acute care hospitals, inpatient rehabilitation facilities, and long-term acute care facilities. Excluded in this particular metric are skilled nursing facility and residential facilities. And the key observation here that I wanted to take away is that in the overall, all population at the top of the table there, we see in the first 2 years, 19 to 20, a 15% year-over-year rate increase. And in the second 2 years, we see a 77% rate increase in number of admissions for an overall 100%, 108% rate increase. But we look at the CHAP expansion population, and the group started out quite high with a smaller population and grew over time. But that first two sets of years, we saw a 70% year-over-year decrease in those number of admissions, a slight increase in the second set of years, and an overall 20% decrease in facility admissions. Again, COVID is strong in effect here and needs to be taken into account. The second metric is acute care bed days. So that's the kind of total number of admitted bed days in each of those acute care facilities. And the thing that draws my mind and eye here is that for the 673 CHAP expansion members, that's the total population in 2021, we see more than half of the raw bed days for 2021. So that population is using more than half of the bed days. The bed day rates are skewed for some of the very small populations and other rows here. And again, COVID's a clear driver of admissions and other utilization. The third metric is 30-day acute care readmission. So in general, if you get readmitted to a facility within 30 days of being discharged for a similar or same diagnosis, that's not a desirable outcome. Overall, for the overall population, we see a 30% increase in the rate from 14 to 19 in those first 2 years. a 92% increase in the second 2 years, and an overall increase for their overall population. Compared to the CHAP expansion population, from that first two set of years, we see a 38% decrease in the rate, a slight, like a 3% increase in the second two sets of years, and overall, from 19 to 21, a 36% decrease in those readmissions. So these different rates could reflect our case management emphasis on discharge planning and follow-up. They could reflect our high case management participation and engagement rates for the CHAP expansion population, but they need to be interpreted in the context of the other two slides of the bed days and the admissions, which it's a kind of complete picture we have to look at. And then the final metric here is emergency department visits, so rates of emergency department visits. And these data comprise the treat and release visits. If you get admitted, you're excluded from this measure. If you go to the ER and need to be admitted to hospital. Overall, we have moderate rates with an increase over time for the total population. And then in the CHAP expansion population, we have high rates with a decrease over time in the rate. And the thing I take away from this is I would be really interested to look at segmenting emergency department utilization by new members into the CHAP expansion population compared to re-enrollees. So that's just a comment to ourselves for the CHAP study that we're getting underway. Again, COVID caveat to some of these numbers. And then finally, just to look at primary care utilization time check. I have like a minute or two.
9.
I have how many minutes left?
Let's move forward.
Okay. For utilization, we want to take a look at primary care. So on page 23, we've provided a more extensive listing of tables for the segments of the population. We're just interested in kind of broad strokes, who's taking care of our members. And I've excerpted here CHAP expansion, all members, and then just non-CHAP expansion. But you can see the other segments on that table. I think the main takeaway that I would present here is that for the whole 3-year time horizon, CUC and ARC practitioners served as the primary care provider for the majority of both our overall population as well as for our highest risk segment. You'll see that in the table, not on the slide. With Seton Family of Doctors coming in at a distant third, taking care of the primary care for just over 5% of our overall membership and our highest risk membership in 2021. Seton doesn't make the list of the top 3 primary care providers for the CHAP expansion population in any of the 3 years that we present here. And just a couple of other observations. Lone Star moved into 3rd place for CHAP expansion primary care provision, overtaking Peoples in 2021. And then just a couple of other pieces from that table in front of you. Year over year, CUC continued to serve as the primary care provider to most of the Sendero members with disabilities. That's one of our segments. And then Hispanic and non-Hispanic members remain fairly evenly distributed across CUC, ARC, and Seton. The vast majority of members with diabetes were in primary care with either ARC or CUC. And CUC remained the largest primary care provider for members experiencing limited transportation access. Remember, that was the social determinant group that we selected. And then my last slide here is just some comments that we hope were interesting, or that we found interesting. So some selected highlights here. This report has been really core and really kind of pivotal for our own population management, planning, and programming. And we would hope that it would be, of use to other colleagues across Central Health, especially as Central Health plans its direct practice of care approach and strategy. We offer this as a bit of a comment. So on page 24 and 25, you'll see tables of just kind of counts. It's a very high level, but counts of numbers of specialty visits, just a very high level utilization of specialty care for all of our members. I've synthesized that a bit into CHAP expansion versus like non-CHAP expansion. So we kind of added all the other groups together versus the CHAP expansion population for 2021 here in this table. Those tables list utilization for the top 10 most common specialties. I've pulled out a few categories of interest. These aren't like the first 3 or anything, but they're the ones that hit in the different groups tables, so that the report gave me numbers to compare. and that were interesting. And so I think the takeaway here is that we see large proportions of the CHOP expansion program membership for plan year 2021 under the active care of cardiologists and ophthalmologists and gastroenterologists, which is funny, it was like very similar to the other, the list of 3 providers that were highlighted earlier, and we didn't plan that. But we see that compared to other Sendero members who are smaller proportions of our members are getting that care. This isn't for you to deduct from, it's just kind of a comment about volume. The CHOP expansion program membership was also under the care of nephrologists, 14% under care of the population was with nephrology, 13% was under the care of a general surgeon. I haven't pulled that out in the table here. And again, there are a number of others that we could go further into detail as we're undertaking this CHOP study and further investigations. There's an additional menu on demographics that this body had requested of Sendero that we have presented to our board that we bring for your attention here as well. But I don't have to go over those if we need to move on to the next item, or I could highlight them briefly.
Can you highlight it because this was a board request?
So moving on to the next memo that we provided, there's a demographics memo. So the quality department under Allegra's leadership built upon the tables that are in the very beginning of the population assessment we just reviewed and did a deeper dive into this data after we received the requests from Manager Jones and others recently. So what we've shown here is self-reported race and ethnicity for all members. I'm going to flip through briefly here. For the CHOP expansion program membership and for what we internally refer to as PAP or the Hammond Sims program, premium assistance program members, and also for regular ideal care. Caveat is that I think we've shared this before, but health plans are statutorily prohibited from requiring race and ethnicity data, and so this is all self-reported. If you would like to report it, then we would love to have that data is kind of how it's presented because it helps us fine-tune and improve our programs. But we do capture kind of the unreporting category, and it's not insubstantial across these segments. I think the key observations with, a nod to the interest that you will have in the CHOP expansion program membership is that, and again, this is for 2022. That's the update from the population assessment tables that you have in the other report. But the CHOP expansion program membership in 2022 reported being of white race less frequently than in the other segments. The PAP, the premium assistance, and the regular ideal care members reported being of Black or African American race more frequently. Declined to report race more frequently, and then also reported being of Hispanic or Latino ethnicity much more frequently than in the other segments. 60% of CHOP expansion members who reported ethnicity in those 2 categories, or in that category. And that's really as much as
Thank you. Appreciate that.
We are already starting efforts to repeat this report this next year. We've fine-tuned the segments. We're going to be including the premium assistance program segment as well as ideal care and CHOP segments in the population assessment to better inform conversations like the CHOP study and internal central health priorities. We really appreciate the chance to share these highlights and
thank you.
And are excited about getting to dialogue about this with you.
I hope that you will hang around. So we'll move on to community care and then we'll take on the questions. Thank you so much, appreciate it. And you guys were good on time. Thank you. So we are having right now Dr. Jason Fournier and Tara Trower will be presenting from community care. Welcome, it's good to see you both. It's been a while since you've been here with us. So the floor is yours.
Yeah, thank you so much. Good evening, managers. It's our distinct privilege to be here this evening. Included in your packet was a quarterly report that was provided probably a couple of weeks ago or so as part of the strategic planning committee, board committee materials, and then again this evening. We don't have a formal presentation. We'll just kind of walk you through the data that was provided, and of course we're happy to answer any questions. But the quarter ending March 31st of 2023 is a 6-month period for our fiscal year, and so that aligns with the report period that we're speaking to. And so one of our major initiatives that we have is, of course, always looking at our access to care initiatives, which means direct provision of services. And so we're very pleased to report that we served 92,462 unique individuals through the first 6 months. That represents an increase of about 2,000 unique individuals year over year comparative to last year. So just for some perspective overall. When we take a look at our patient population, it consistently is trending at about 48% uninsured. The vast majority of our uninsured are adults. So when we take a look at our adult population, it's about 68% of the patients that we're serving are uninsured. And then when we look at our pediatric population, roughly around 80% are either covered through the Medicaid program or the CHIP, the Children's Health Insurance Program. What we're seeing is a little bit of a growth in our geriatric or over 65 years of age population. It's now at 6.8%, so that is a population that's been growing within our services that we're seeing year over year. So we take a look, what we're presenting is the first 6 months, but we always take a look back for the same period last year and look at how much growth we've experienced or not experienced. What is very stark within the report that you'll note is that 61.1% of our patients are best served in a language other than English. And that's for the individuals who report. Not everyone reports with their language. But one of the things, if we look back a couple of years ago, that number was sitting at about 37%. It isn't that it's transitioned that much, but part of the investment that you as the board previously approved for EPIC as our healthcare system, our electronic medical record system, has allowed for a better data capture. So we have a better accounting for what languages our individuals are best served in. Of course, the first language that we serve is Spanish. Number 2 is English, and then so on and so forth. And we reported Pashto, Burmese, and other languages are within the report as well, so you can see. When we look at the changes relative to the report overall, not only is it about access, but it's also about increasing equity, and we have social determinant of health initiatives that we have ongoing as part of our strategic plan. And you'll see that towards the bottom of the very first page in terms of outlining what our board of directors has approved as our 3-year strategic priorities. And one of those is as it relates to looking at resourcefulness and engaging in the social determinant or non-medical drivers of health initiatives. Happy to report that within the first 6 months and in this quarter, we actually implemented Find Help, which you probably might be aware of as formerly Aunt Bertha's, which has gone ahead and actually expanded, and now it's Find Help. You can go online, you can actually see resources. What's more unique about our deployment of it, it's embedded within EPIC, and so our folks are able to, our frontline staff are able to make referrals to non-governmental organizations or social services entities, and those referrals cross over to them via the Find Help platform. So our patients can go on and search findhelp.org, see where there's food available, other resources that they might need. The next phase of that, which actually flipped on in March, is the bidirectionality, which means when we send out a referral, it comes back to us via EPIC as well, and we know whether or not there is a closing, what we refer to as a closing of the loop as it relates to that. Another exciting partnership, and using some federal funds that we had access to, we're establishing for the first time within North Central Health Center as well as Southeast Health and Wellness, a medical legal partnership where we've partnered with Texas Legal Services. And so there'll be, that partnership has been executed, had to recruit the attorney. The attorney isn't actually starting on until August, but it'll be the first time as part of our services, there'll be actually medical legal services available to help with, for example, disability applications, immigration-related issues, domestic violence-related issues at no cost to patients that are being served within those health centers. Of course, that'll be a conduit for patients from our other health centers as well. And so that's something we're very excited about. One of the other things that our medical leadership and nursing leadership and operational teams delivered on was we've been working for several years post-implementation of EPIC. Actually, March 27th of 2023 marked 2 years plus go live from EPIC, so it's always a journey, right? One of the journeys is that our teams have been working very, very deliberately on establishing what's referred to as gold standard workflows within our EPIC deployment. And that was completed for both our internal medicine practices and our pediatrics. Family medicine actually occurred last year, and they're working on obstetrics gynecology right now. It doesn't mean that these are the gold standard workflows. There, of course, are workflows in process for that. One of the things that we did highlight is thanks to some expanding coronavirus vaccination monies through the federal government, we delivered in the quarter beginning January 1st through the end of March, 31 outreach initiatives where there's education provided on the need for COVID-19 vaccines, but actually the delivery of vaccines into the arms of individuals through those events. And that's something that we are doing in partnership and via contract with the Medical Response Unit from Ascension. And then finally, one of the more important ones that I'll report on, then turn over to Tara to go ahead and give you an update in terms of some of our enabling services initiatives over the last 6 months, and really specifically to the quarter that we're reporting on, which is, again, from January 1st through the end of March, is our staff, right? Like many healthcare providers, not only locally but across the country, we've experienced higher vacancies than we had pre-COVID or during COVID. By way of example, our provider vacancy rate was sitting at about 4% or so to 5% throughout the pandemic. It's now in double digits, lower double digits, but it was about 14% or so. And that, to the points made earlier in this evening's meetings, part of it's the affordability within the area, attracting talent to the area. There's a lot of different factors that are playing into it. But our hiring ratio for the quarter was 1.4 times more folks hired than lost. So we're ahead of the curve overall in staffing, but we have critically important needs beyond just direct providers. It's the support staff, right? Our clinicians are only as good as the folks that are supporting them. So finding nurses, medical assistants, dental hygienists, those are high-need positions that our board of directors has indicated, and we have a different model for compensation for those high-need positions that have been identified. So we've made some progress on that, but we're sitting right now on around 300 open positions by way of example, right? Part of that's tied to new growth, anticipated new clinics opening, or expansion, but some of it's just due to the natural transition of what's going on overall as it relates to. One of the most innovative things, though, that we've done of late is we actually, through a program at the federal level, we're able to establish an apprenticeship program for medical assistants, and we launched our first class of 8 apprentices that are coming through. So these are typically high school kiddos who have just graduated. They're coming in, and in lieu of actually going to take a formal course in medical assistantship, they'll actually get credit and be eligible for sitting for their certification. What's unique about this is they're actually paid apprentice. So they're coming through, it's a paid apprenticeship. So it's 8 right now, but by way of perspective, we had 80 applicants. The next class will be in a couple months, and we're looking to add another 10 to 15 overall for your awareness. So very excited about that. We know our peers here at Central Health, as a good colleague, Dr. Salsha, I know he's working on that on your front as well, and it's always a partnership at the enterprise level. And so I'll defer to and hand over to Tara. I'm like, was I not using the mic?
No,
I'm
you
just
were
kidding.
using it.
I'm kidding.
Further away.
I'm kidding. You are further away. So she's just going to give an update on some of the enable services that we've got going on, and then we can dive into the data further if you'd like.
Fantastic. Is this on?
You guys just want to...
It's still... Looks like it might be dead.
So do you think 6 minutes is good enough?
I can go fast.
Okay, thank you.
Very good. Thank you so much. So yes, I'm going to talk to you today about enabling services. Within the walls of community care, one of the words that you hear most often is access. And one of my team members said today that you guys use that word more broadly than anyone else I've ever heard. And that really is true, and it's reflection of the communities that we serve because of our focus on individuals under 200% of FPL. Access is not just the appointment slots, but it's also those other things that make accessing healthcare challenging. And so we have been doing enabling services for quite a long time. It's one of our charges as a community health center, and we report those services to HRSA. However, we've really focused on using the investments that we've made in Epic. One, Jason has already mentioned with reference to findhelp.org, but the other tools that we have at our disposal to really help connect folks to care and make it easier for them to access care. So case in point, and I heard Dr. Jennings talk about the use of Lyft. As you all know, transit is really challenging within Travis County, and for many of the communities we serve, they may not have access to mass transit, and so we have to use a number of different tools. We've always had bus passes and relationships with taxi services, and because of the investment that you've enabled for Epic, we have been able to embed Lyft also into the electronic health record. So if an individual has an appointment, one of our team members can click a few buttons, schedule a ride, both there and back home, which is really useful given the transportation challenges that folks have. We also have done an expansion of online eligibility assistance using RedCap, which actually we got substantial help from the folks at Joint Tech, which first used it within the MAP program. We have a broader array of funding sources available and the ability for families to upload their documents in real time that they may not have with them in person has really speeded the process and has been very well received. We are also in the process of and have completed a strategic alignment of our interpretation services. We've changed vendors. We are also working to hire more in-house medically certified translators to better connect and have a better patient experience for our patients. Jason mentioned the numbers that we're talking about in terms of those best served in a language other than English. And so whether it's our patient navigation center within the clinics themselves, working to make sure that they have that real-time connection in the language that they are best served in. We have also increased our investment in care management, inclusive of additional team members that are really focused on population health, chronic disease outcome, and preventative services. And then a lot of work has gone into, in collaboration with our colleagues here at Central Health, in educating folks about the end of the public health emergency and how it affects those who have been on extended Medicaid. Letting folks know these are the things that you need to do in order to prevent your coverage from lapsing, and if they are now better suited for MAP, making sure that they make those really important transitions. And so all of those fall into the access bucket, but are really about the ways that our patients are more challenged than other communities to connect to healthcare. In real access, I just want to quickly highlight some really exciting initiatives that we've done as well, including adding Saturday clinic hours at North Central for our women's health appointments. We did a quick survey to find out whether or not those appointments would be used. A lot of it's family planning and other visits that are tough to make during the work week or because of childcare issues, and that has been very well received. We've also initiated free pregnancy tests across all health centers, something that was provided in some sites pre-COVID. We have reinstituted that and expanded it, particularly given the changing landscape with regards to women's health here in Texas. We have also are really taking a hard look at our appointment scheduling and call center strategies to really bring down those hold times, as well as make sure that we're making the best use of the slots that we have in a way that patients can get in more quickly and we can serve them more efficiently. And last but not least, we established services in the reporting period at the Black Men's Health Clinic. We've also ramped up services at Aikens Early College High School as our first federally funded school-based services site, of which we're looking forward to doing more of. We're currently operating out of the RV one day a week and looking forward to hopefully being able to expand in the coming school year. And that's really high-level overview in terms of the many, many initiatives that we have, and I'm happy to entertain any questions, as is Jason, on what we've talked about today.
Thank you so much. Appreciate it. And congratulations on your expansion, Pflugerville. That is amazing. Sorry I could not,
Next report.
Yes.
not be there, but appreciate it. So at this moment in time, I'm going to open the floor for questions. I'm going to start with Dr. Bell. Are you still there with us? He may have stepped away, so I will start with Manager Martin. Do you have any questions for both items? I will take Sendero and community care. Thank you so much. Manager Motwani?
My question is around 1575, or House Bill, I think 1575, that Abbott signed, I think. And if there are any implications on the upcoming fiscal in as much as ability to be hearing about find help and hearing about this non-medical drivers, I don't know exactly what the implications are because I don't follow the legislature as closely as maybe I'd like to. But my understanding is that pathways for Medicaid reimbursal for CHWs, used specifically at minimum as related to CHWs and doulas and their care as far as non-medical drivers for pregnant Texans is concerned. Are there any implications there?
We need to evaluate that. It's not one that was on our radar screen as tracking, so we have to look at the bill itself. It's not through our trade association, the Texas Association of Community Health Centers. There was an analysis that was done, and we haven't done that analysis internally. We certainly have community health workers. I think we're upwards now of 20 or so.
Nearly 2 dozen.
Yeah. So quite a few, considering, sort of 5 years ago, I think we had one or two. So there's opportunities, and with partnership and in partnership with Central Health, we're working with a doula program as well for our prenatal population. So we'll look at that, and we have to report back in the next quarter and just write down what.
Sure you will, yeah. Just wondering if there's any early preview, but it is pretty fresh, so thanks.
Yeah, the other one within the legislature that we're very pleased with is a change from 2 months coverage.
Oh, of course.
To 12 months.
Yeah, that's great, Rides. Thank you so much. Do you have further questions?
Thank you.
Thank you. Manager Kitchen?
Yes, I was intrigued by two things that you mentioned related to the functionalities for Epic, I guess it is, and just wanted to ask a question about them. One of them was the closed loop referrals. So does that all happen within the Epic platform?
Yes and no.
Okay.
So our side happens within the Epic platform.
Okay.
But it's actually, there's a connection that community members, so social service entities can come in either through the website or through our extension of the platform to them so that they can go ahead and actually indicate that they've communicated and connected the patient with the needed services.
Okay, so on their end, they need to take an action to let you know that they followed up on a referral.
That's correct, yes.
Okay. Okay. And it's not connected to their system where they might?
It's not. The vast majority of social service entities, because of how well Find Help is used in the community, they're using the platform. And the other part that we were remiss in indicating, Manager Kitchen, is that patients can go in also, or community members can go in and close that. So they'll see those too. They can let us know that they've actually got connected to a service.
Okay. I'd love to learn more about that. So maybe if you have a description of it somewhere, you could send it over.
Yeah, we can follow up with that.
Absolutely.
Yeah, for sure.
And then the second question was about the lift being embedded. Is that, I didn't catch what you said, is that for a staff person to go in and schedule the trip?
So yes, if someone has an appointment and they've indicated that they have a transportation issue as part of the screening that we do, the staff member, I believe it's front desk folks, can go ahead, go into the appointment, schedule it at the appropriate time, and then schedule the return.
Okay, thank you.
And for clarity on that, right now we're going through a different platform with Lyft.
Okay.
So we use their interface, but it's a commercial healthcare, and it's being built out right now. So when we put the report together, we got a little ahead of our skis and reported that it was already there. It's not quite there yet. They're working on it. Yeah, very close.
Thank you.
Yeah.
Thank you, Manager Kitchen. I see Dr. Bell have joined again. Do you have any questions about the Sendero item or community care?
No, I don't. Thank you very much.
Thank you. Manager Jones?
Yeah, I have just two quick questions. One for community care and the other one's for Sendero. Community care, can you give us an update on how the Black Men's Health Clinic in terms of outreach? I know it's very new, it's very. I'd like to thank you all for working with them. I think it goes a long ways to addressing some of the significant disparities we see in health. But just in a preliminary, do you have any updates on terms of how that's working or the interaction or interplay with you all?
I don't have the numbers top of mind, but I can tell you general trends. We have gone ahead and hired a provider who is permanently assigned to that site. We are still only there once a week. But we have seen uptake of appointments increase with the addition of that provider. One of the things that our teams are still looking at is the no-show rate. So we're scheduling all of the slots, but as we experience with many of our other clinical sites, the no-show rate continues to be a challenge in finding out what the root cause of that is. We do also have a community health worker assigned to the site, and thanks to the funds that Board of Managers provided, we are working with the Black Men's Health Clinic staff, and they have hired outreach workers who are going out into the community, many individuals with lived experience who are making those connections with patients. And so they are, African American men, Latino men, men of color, white men, we even have a few women. And so we're still building that out and looking to add a second day to really better understand what sort of access is desired and what would work best for that site, even though there's some limitations in terms of the scope of services we can provide out of that location.
So Manager Jones, in the upcoming report that'll be coming, I think the next one's going to be due probably July, August. We'll make sure that we include and bifurcated, here are the outreach activities. Much of that is already indicated is being done by our colleagues at the Black Men's Health Clinic. That's part of the arrangement that we have with them, in coordination with our community health worker. Then coupled to that is there's an additional, we have another medical provider that we expect to be hired and onboarding here in the not too distant future, who's representative of the community served and male.
Thanks very much. I've heard a lot of great things both here and nationally, in fact, in terms of that clinic and what they're doing. So thank you for supporting them there. It might be also helpful over time to be able to look at rates or of utilization by Black men at this clinic versus Black men at some of the other clinics, just to see whether or not there's anything uniqueness about that. So thanks very much.
Absolutely.
The other question I had is for Sendero.
If I may, and I confirm by moves, I recommend if there's other questions for community care, that way we're playing musical chairs.
Can I just?
Back and forth, but it's the chairs and the members' call, I just thought I'd suggest that.
I know, if it's quick, let's just take Sendero right now and just move on. We have 3 other board members, and then we can.
Okay, my question is, on your.
Yeah, just stay where you're at. And
Thank you.
we can pass the microphone.
On your, so one of you all can come up here. On your utilization chart here, you talk about members.
Which table?
Page 15, 30-day acute care remission, and you have it in your other categories too. Are these individuals who have identified as you've said that they self-selected their ethnicity? Is that right?
Yeah, I'm looking at the wrong page, but our race and ethnicity data is self-reported.
Self-reported. So it's not necessarily.
It's actually pretty free-form. It doesn't look like the census. So this is something that's set by the fields are or set by our enrollment vendor. We've pushed, starting in the last year or two, that they align and better standardize their fields. I would expect that they would match the census categories, but they don't. And they combine race and ethnicity with, they combine race and ethnicity basically into one column. So we've, there's some, the Latin American piece, for example, is not standard in the census. But we wanted to honor how people might write, I'm Cuban, I'm Cubano, or whatever. We didn't want to kind of erase that data, and it was a substantial proportion. 5% of our members wrote something in that segment. So rather than giving them a kind of a zero on, or giving them no data on race, we kind of creatively created that category for them, if that's what your eye is drawn to. But
yeah, that's what I was sort of going at, is how when we look at ethnicity, and I don't want to get in a public health discussion either, but race and ethnicity crosses. And the question is, who determines that? And based upon however one self-identifies, do we take the data that we gather from that and then make certain decisions based upon what collectively our aggregate data says? So for instance, if we have a large number of Puerto Ricans who may identify as Black, who receive services, what does their data, health outcomes look like? Then those may be Mexicans who may not identify as white. And so I was just trying to see, do you have any way, and I know it's difficult because in public health it's difficult to do as well, but I didn't know if you have any concept in terms of what you're seeing, because you see it on the ground. You're not just collecting data, but you see it in terms of that. So that was the question I was trying to get at.
yeah, thank you. I don't have a great answer to that, other than that, we tried not to assign people and to let them kind of self-express in this data as an ideational kind of approach to what we're presenting here. But we can take that into our next population assessment planning as well.
Yeah, it would be helpful. I just raised that question as something, I've been looking here locally to see what it looks like, and it's hard to get that festered out like that.
Yeah.
So it'd be, if you all can do it, it'd be helpful.
Thanks for that.
Thanks very much.
Thank you, Manager Jones. Dr. Mark?
No questions for either.
Thank you. Manager Valdez?
I have questions for both. And I just follow up
Can you turn on your microphone?
Just to follow up on Manager Jones's comment about the self-identification issue. I think a lot of that stems to the racist days of you're born Mexican or you're born white on the birth certificates. My birth certificate says I'm Mexican. There are others, because I'm in the valley, falling in the river, but there are others that are Latino that were born, they're white, identified as white. So it's the government imposing itself on who, taking that away from us and further confusing our own ability to determine for ourselves or keeping our own identities. I think that's part of the problem. And so we're trying to overcome the systemic racist systems with respect to that. Regarding the Black Man's Clinic, I know that you all have a number of Latinos that are receiving services there. Can you tell, or have you been able to determine whether or not maybe a cause for the no-shows could be that they're in the construction business or self-employed, and so if it just so happens that because they're paid differently by the hour or by the day, if it's raining or the weather's bad, they can come in, but if it's not, they have to work. Has that been taken into consideration?
It has not, but it's a great suggestion for us to better understand. And
Yes.
we've got a work group that's really looking at what we refer to as our no-call, no-shows to our appointments broadly. And so we can look not only at the Black Men's Health Clinic, but across our system.
But across the board.
And look at patterns relative to our no
Because that is a I know millions of people, it feels like millions of people, everybody I know is in that category. And so if you actually inquire from them, are you self-employed? Are you a contract laborer? Are you whatever? Are you paid by the hour, paid by the day? Are you salaried? That's always, are you salaried, I guess would be the question to ask, because there's gonna be a lot of contractors or people who are in the construction business as per day who will say they're not salaried. And those are the ones that are gonna have a problem. They wanna work, and they'll work 7 days straight if there is good weather, but they will not work. I mean, they won't work and they can therefore utilize the clinic if it's bad weather.
Well, it's
So-
one of the reasons why we're very deliberately trying to go
Well-
ahead and increase what we refer to as on-demand services. So not just walk-in, but within the clinic environment overall on-demand. Tara was going to add something.
It's okay. That is a very good observation. One of the things in having a CHW there
Fine.
on site is following up with folks after the fact. And so I will make sure that as she kind of probes as to why folks come in and why they don't, that she asks some of those questions.
Especially if transportation is an issue, and that's for both males and females. Because males, they'll tend to have friends pick them up and they're traveling in packs, 5 people in one truck or more. And women, whoever's working at the hotel or wherever it is, can they get there or not? So thank you for that.
Just a
also
small
on the-
comment, sorry. Now, just giving to be very sensitive to the topic men and female, we need to be inclusive for all as well. Just wanted to bring that up to everyone's attention.
Of course.
Just, those who are non-binary, just also make sure. Thank you.
Everybody. And with respect to your board members,
Yes, ma'am.
I didn't see how long they've been on here. If somebody can do that, just send it out to us. If some people have been on for 1 year and some people have been on for 50 years, I don't think so, but that would be interesting.
Not 50, but I think we have someone 13.
Yeah, I know.
That's an oversight on our part.
No,
We'll
but
correct that.
that's important to know.
Yep.
Okay?
We will go ahead and send that refreshed over to Mike to be shared with you. Apologies for that oversight.
No, thank you very much. And Sendero, with respect to, you were taking into, where is it? That you were excluding the population living in SNFs and residential institutions. What was the reason for excluding that population? Because they're on long-term Medicaid or what?
So they get included in other appropriate indicators, but it's mostly just referring to, in many cases, that's the definition that comes from NCQA or that is kind of inserted into some of their reporting. So you just have to, you have to be crisp about what you're defining so you know what's in and what isn't. But it's mostly referring to technical specifications or deferring to technical specifications from our accrediting bodies.
I was just curious as to whether or not that was a consideration, because once they're in long-term, it's long-term Medicaid, it's different. But if they're in residential, are they even going to the clinic for appointments? The clinics, I'm sorry, for community care or wherever. Okay, and let's see. I think that's those are the only questions I have right now. Thank you very much. And let me tell you, I appreciate both your agencies. Oh, with respect to the changes that are coming down the pike, I'd like to know whether or not you see community care, whether we should be considering as a board changes in the income levels for eligibility services. Have you all looked at that? Because I have spoken to a lot of people who sometimes get denied because they had $5 over the limit, and I know that's an opportunity for them to maybe try and work through the not basic program, but I'm just curious as to whether or not there has been, and I guess maybe Jeff, but for y'all, whether there has been an ability to assess that, to look at that, to evaluate, and tell us whether or not there is a need to maybe reconsider the income levels because of the changing economic situation of the people who are living in our poverty population.
So I think
or working poor population especially.
Yeah, Manager Valada, you are spot on. I think it's something that needs to be evaluated. We're in the midst of performing our most up-to-date community health needs assessment. One of the things that we're doing is both for Travis County and the MSA at large
Right.
is looking at the change over time and trending to see are less than 100% federal poverty level, less than 200%, staggering it. There isn't a cut point in the census data at 250, so we're using it as a barometer, 300%, and we're considering that. And then we're also having conversations at the national level in terms of how the federal poverty tables don't work for an urban low-income population, because it does and still
right.
continues to take into consideration affordability, and there isn't a geographic adjustment relative to
That's
poverty
right.
tables for how high cost an area is. And candidly, the mechanism in computing federal poverty table hasn't been updated since the 60s.
That's right.
And it's mostly reflective of
That's
basic
50 years.
needs to go ahead and feed to oneself and their family, not all the other factors. So we're sensitive to that. We haven't engaged our partners over at Central Health yet on that because we're doing some evaluative work. But we are hearing very similar from our patients. We used to qualify as a Travis County resident for these benefits, and now we're not. And this at the
That's
national
right.
level is important because, as you know, our cut point for participation for sliding fee scale for community health centers is at it's less 200% or below,
Right.
and there's been no adjustment in that either for years and years as well. So we're engaged in that
That's-
conversation and issue.
That's
going
very
forward.
important to me.
Yep.
I mean, it's like one of the most important things for me right now. Also, the consideration for transportation for those that don't have transportation, that may be in a wheelchair or can't walk, and trying to get entities to come out and pick them up. Even if you have Lyft, Lyft has got to have a van that can accommodate them, and so all those other considerations, please.
Thank you so much
If
for
there's
those
anything,
comments.
any way that I can speak or follow up with you,
Yeah,
with
we'll-
respect to this?
We can follow up on that.
Thank you,
I
Manager
appreciate it.
Valdez,
Thank
for
you.
raising that important issue.
Thank you.
Appreciate it. Thank you all for coming before us tonight. I have a question. Yeah, oh, sorry, she already, I apologize. I did not skip Manager Brinson at all. She indicated she had no further questions. Well, again, thank you all, appreciate you, and there was no motion for this item. Thank you. Have a good evening. So item number 5, discuss and take appropriate action on delegations to the President and CEO to execute necessary agreements between Central Health Travis County and Mazars USA regarding the performance review contracted for by Travis County. Mr. Mike Giesland and Monica Crowley will be presenting. Mr. Giesland will be presenting a few remarks before we go into closed session.
Yes, thank you, members. And before we go into close, I just wanted to say that this is an important step for us because an interlocal agreement between us and the county allows us to transact business. And so that's the essence of this interlocal agreement, also referred to in shorthand as ILA. And while we do need to go into closed session to establish attorney-client privilege and discuss some matters with you, just wanted to emphasize that once we're able to authorize the CEO to execute on this, then we can get started in earnest and with the review activities. There's been some high-level discussions and meetings and introductions, but just wanted to emphasize the importance of this document. It's something that we need to say in open session. Thank you.
Thank you so much, Mr. Giesland. So at this time, I announce that the board is convening in closed session to discuss agenda item 5 under Texas Government Code 551.071, consultation with attorney. And it is June 14th, 6 p.m. Thank you. We're good? Thank you all. We are out of closed session. We are back and open. May I have a motion, Manager Kitchen? Yes. Oh, sorry. It is, sorry, it's been a long night. It is June 14th, 7:26 p.m., and we are discussing item number 5, discuss and take appropriate action on delegations to the President and CEO to execute necessary agreements between Central Health, Travis County, and Mazars USA regarding the performance review contracted for by the Travis County. Manager Kitchen, may I have a motion, please?
Okay. I move that the Budget and Finance Committee recommend to the Board of Managers authorize the CEO to negotiate any agreements necessary to ensure effective participation by the Central Health Enterprise in the Travis County auditing process.
Thank you. I have a motion by Manager Kitchen and a second by Manager Valdez.
I'll second it, but Manager Kitchen, do you mind adding the word appropriate? Effective and appropriate?
Sure, that's fine.
Thank you.
So we have a motion by Manager Kitchen and a second by Manager Valdez that was slightly amended. And Manager Kitchen agreed, approved the amendment. Now, any discussions on that item? I see no further discussions. Are we all in favor of this motion?
Aye.
Manager Bell? Okay, so
Aye.
I see it, so the motion carries unanimously. Thank you all, appreciate it. Now, the last item is item 8, confirm the next Budget and Finance Committee meeting date and time and location. Managers, our next Central Health Budget and Finance Committee is tentatively scheduled for Wednesday, July 26, 2023 at 4 p.m. at the Central Health Headquarters, 1111 East Cesar Chavez, Austin, Texas 78702. At this time, I am ready to accept a motion for adjournment. Manager Valdez? Thank you. Thank you. Manager Brinson, all in favor for adjournment? Aye, and this meeting is adjourned. Thank you. This is yours.
Should we just keep moving?
Keep moving.
Hello, this is the Executive Committee meeting, and today is Wednesday, June 14th, 2023, and it is now 7:28 p.m. The first item of business is public communication. We will receive public communication for both the Executive Committee and the Board of Managers meetings before we proceed to the Executive Committee meeting. Members of the public who wish to make comments during the public communication portion of the meeting must have registered with Central Health via the online form or by telephone no later than 2:30 p.m. today. Yesenia, did anyone register to make comments for either the Executive Committee meeting or the Board of Managers meeting? No one has signed up. Okay. So we will now proceed to the Executive Committee agenda. Item number 1, approve the minutes of the Central Health Executive Committee April 26th and May 24th meetings.
I move approval of the minutes for the April 24th and the
April 26th.
April 26th and the May 24th, 2023 meetings.
Thank you. Manager Valadez has moved. Do I have a second?
I second.
Thank you. And Manager Saita has seconded.
Okay, almost.
So all in favor?
Aye.
Okay. All right. So we will move forward. Number 2, review and provide direction to staff on the prioritization and tentative scheduling of items for consideration at future Central Health Board and Committee meetings. And Brianna Yanis will be presenting.
I will first go over the June meetings. We have 2 meetings left in June. The ad hoc succession committee meeting on June 26th, and then a special call Board of Managers meeting on June 28th, where we'll have a guidehouse update and then health districts, and then discuss health districts and HMO ownership. And then in July, we have a tentative ad hoc board appointments committee scheduled for July 19th. And then we do not have a strategic planning committee meeting. And then on July 26th, for budget and finance, we have our minutes, May financials and capital projects update, budget forecasts, and Q3 fiscal and operational updates from CUC and Sendero. For executive committee, we have minutes, tentative schedules, discuss research and survey reports in alignment with board responsibilities, and then CUC and Sendero governance discussions. And then for the Board of Managers meeting, we currently have minutes, investments, the Dell Medical School update, Sendero update, and lawsuit standing update. That's all I have.
All right, so no motion will be necessary, but does anyone have any comments for Brianna Yanis? Seeing none, we will move forward. Thank you so much, Brianna. No motion will be necessary, so that's fine. Confirm the next regular executive committee meeting date, time, and location. Managers, our next Central Health Executive Committee meeting is tentatively scheduled for Wednesday, July 26th, 2023 at 4 p.m. or immediately after the Budget and Finance Committee meeting at Central Health Administrative Offices, 1111 East Cesar Savage Street, Austin, Texas, 78702. And at this time, I am ready to accept a motion for adjournment.
I move we adjourn.
Manager Valadez moves to adjourn.
I second.
Musaitis seconds. Everyone in agreement?
Yeah.
Yes, okay. Aye. So this meeting it is June the 14th, and it's 7:32 p.m., so the executive committee meeting is now closed. All right, now we're going to the Board of Managers meeting. So today is June 14th, 2023, and the time is 7:33 p.m. Okay. So, managers, the agenda will be taken slightly out of order this evening. Item 3 will be considered last before adjournment. Also, there are 2 items that will not be taken up on the agenda this evening. Those were the litigation briefings under agenda items 5 and 6. The first item of business will be the consent agenda. C1, approve the minutes of Central Health Board of Managers May 24th, 2023 meeting. C2, receive the quarterly investment report and ratify Central Health investments for May 2023. C3, approve setting the Central Health tax year 2023 homestead property tax exemption for Travis County residents who are over 65 or disabled as recommended by the Budget and Finance Committee. C4, approve a resolution of the Board of Managers of the Travis County Healthcare District approving the issuance and the terms and provisions and pricing of the district's certification of obligations in an amount not to exceed $100 million, approving the form of and requesting that the Travis County Commissioners Court approve and adopt orders to authorize the issuance of such certificates and other related matters as recommended by the Budget and Finance Committee. And C5, approve an agreement with J.P. Morgan Chase for depository services as recommended by the Budget and Finance Committee. Do I have a motion to approve C1 through C5? Manager Valadez approves, and do I have a second? Manager Martin is the second, and so everyone in agreement, vote? Aye. Good. Okay, we will now proceed to the regular agenda. Discuss and take appropriate action on delegations. We did that.
In Budget and Finance.
Oh, I'm sorry.
Do we have to approve it officially?
Oh, we have to approve it.
That was just a
Yeah, it was a recommendation to the board.
All right, I got you. Okay.
Yeah.
So discuss and take appropriate action on delegations to the President and CEO to execute necessary agreements between Central Health, Travis County, and Mazors USA regarding the performance review contracted for by Travis County. Mike Giesman, are you presenting?
No, Madam Chair, no presentation necessary. I think given the Budget and Finance Committee recommendation, in open session.
And so do we move to deny this?
No, what you would move to accept the recommendation from the Budget and Finance Committee.
Thank you. And so do I have a manager to accept the recommendation by the Executive Committee?
So, do I say the whole motion?
Yes.
You could just say exactly as they just did, and we have it on the record.
Accept the recommendation by the Budget and Finance Committee.
Thank you. All vote, please.
Aye.
Aye. Unanimous vote. And, all right, great. I announce that the board is convening in closed session to discuss Agenda Item 1 under Texas Government Code 551.071.
We have an open presentation, and and I want to apologize for the confusion, but we've properly disposed of one, and so the closed session will only apply to the real estate item after Stephanie McDonald presents.
We're going to go into executive session only for stuff.
Item number 4.
Real estate issue.
So we will.
Okay.
Yeah, we're going to be in open for a little while on item number 4, and then we'll go into closed session.
I apologize. This is still in the open meeting, and today is June the 14th, 2023, and the time is 7:37 p.m. Number 4, discuss Central Health owned or occupied real property and potential property for acquisition, lease, or development in Travis County, including pending issues and next steps in the redevelopment of the Central Health downtown campus, administrative offices of Central Health Enterprise Partners, and new developments in eastern Travis County. And Stephanie Lee McDonald will be presenting.
Thank you, and I'm going to make this part snap because it's stuff to talk about. I'm going to skip over this, but I think you know that we're going to talk about Del Valle and Frisbee Bend. We're on which are both having reported active construction. Next slide, please. And next slide. So just so to give you an update, we are really making significant progress. You can significant progress at the Frisbee Bend. We have a roof. We have HVAC equipment installed on the roof. We are expecting the date of substantial completion of the contractor is August the 22nd. We are hoping that all the stars align with our utility partners. With our utility partners, including Southwest Water Company and Austin Energy, there's a little bit of things that are kind of shaky, but we are hoping very much that we can have services open by the start of the school year, ideally. The school, this is Del Valle ISD, and so I just want to let you know that we had talked about an August 5th event. That August 5th event will likely be a drive-through event. If we're even able to have it on the site, it'll still be in the possession of the general contractor. So there's a back-to-school event, though, that Del Valle ISD is hosting on August 5th. We will move it over to Daly Middle School if needed to accommodate the families in the area. And we provide backpacks, as you know, to many of our patients and the families that we serve. We will do that regardless of where the construction is on August 5th, either at Daly Middle School and then also at Del Valle High School later on. That I think 10 is where it starts at the Del Valle High School. Next slide, please. Just another picture, rainwater system, another picture. And these are actually about a week or so old. Next picture, please, of the interior. Oh, there's a sign out front, the memorial sign. Nice. Power being installed. All the 19 utility poles have been installed.
Good.
The wires are all connected underneath, but the power line, air conditioning, it's all still running on a temporary generator. And there's some interior shots. And like I said, this is actually probably a week and a half old. One of the things that we were really excited about is we worked with Del Valle ISD Art Club, and we have been utilizing the students there. So many of them have graduated, but to help us provide art in the Hornsby Bend Health and Wellness Center. So here's some locations where that art will be located. There's a mural coming. We don't have time to show you, and it's also
tricky, but if you have been following us on social media, you might have seen this video. And next slide is the link to a really great video on Facebook. We call it the Jackalope video because the students have painted things that are kind of unique to their community, and somehow Jackalope resonated with them. But this will be a mural installed and painted in the Health and Wellness Center. Next slide. Del Valle, I want to let you know we did have a slight hiccup. David Duncan likes to call this project snake bit, but we are working through all of those snake bites, and we believe we might have an antidote, and I'll talk a little bit about that later. But next slide, please. The good news is there are actually walls, and these pictures are also a little over a week old or so. Next slide. So I'm going to roll right into Hancock, and I think you have not had any updates on Hancock since we got approval for the project. We have 3 levels at Hancock, and we have a Crackerjack design team. It's a partnership between BGK and BSA, so it gets a little confusing. BSA are the clinical architects, BGK are some of the overall building core and shells we use. So I just want to kind of walk you through, and I don't expect you to, this is not in your packet, we can certainly get these for you. These are still very much in motion. We are trying to wrap up schematic design documents by the end of this month. We still have 2 more design phases, but this really kind of cements where things will be located and in what quantity potentially. The things that are not able to be moved are also starting to be documented. So one of the things you will see here is a stairwell kind of in the lower third of the floor plate. This is actually the lower level. That is a term of art. Some might call it the basement, but we are now rebranding it as the lower level. And in the lower level will be these stairs that come in that well that used to be the escalator. In the Sears, right? This will be a very, nicely done space. We plan to use it to its maximum. And unfortunately, there is a good chunk of it. That left-hand side is all mechanical. There are, in this area where you have our joint tech team, we've got some other potential workstations for team members from across the enterprise, some of our back-of-the-house functions. We do have sterilization for potentially other sites outside of even Hancock located in this area. And we've got some project rooms planned, some other large meeting rooms for use for our staff primarily. And then we do have a very large public auditorium. It's very similar in design to the Seton Administrative Office auditorium on the ground floor over on Philomena Street. So very flexible. It is likely where we will host these meetings. All of our other kind of public events, as you know, this room gets used quite a bit by members of our community. Some of the support spaces, including dedicated AV room, which I think will be really important as we move forward as an organization. There's another large conference room down here. This would be where Community Care would host their board meetings. We could use it as an executive session room if needed as well, or additional space for attendees. And then if you want to go up the stairs or up the elevator to the next floor, please, Brianna. This is actually the clinical level, and this has become really dense. I will share with you that when we originally came to you all, we didn't plan on this being all built out as clinical space. We might be coming back for some more money. We have some requirements right now that we enter into the building from the east, to the side that faces the interstate, and that's on the far right here, towards the lower third. And when you walk in, we hope that you can see kind of all the way to the stairs that go downstairs, but also we created a spine down the middle. On the northeast, so the kind of upper right rectangle that goes down, would be community care space. This is dental, a very robust number of dental seats, laboratories on the very top, focused for adults. And then we have our David Powell Clinic, and that's going to be important. Pin that for our closed session conversation. as well as other kind of primary care space. This would be where convenient care would be relocated, but just think about it as kind of general all-purpose primary care space. And then just at the very bottom is the pharmacy, and that pharmacy would serve all of the enterprise MAP members who utilize the central pharmacy right now. If you see the kind of, there's a little bit of a ladder just to the left of the pharmacy, that is the check-in area for community care, and then it's a lot of open seating in the waiting areas, kind of up that spine, and to the left as well. The left-hand side is the central health clinical space, a real dense mix of specialties, and you can talk to the team over there, John Morgan and Alan Shelsha, about the specialties that are being planned and how they would transition from RZ if you're interested. This document is being refined by our architects as we speak. We are trying to plan for some future services, including potentially infusion and the lower, very bottom level, hopefully to get a little bit of daylight. And that has been something that we've been really trying to do, is create daylight as much as possible throughout the clinic spaces and using those window areas, those big plate window areas effectively. We have a lab that would be shared at the bottom, pretty large. Quest right now is the lab operator for community care, so we envision it being a Quest site. There is also in the middle between the Central Health Clinical Space and the Quest Lab, the check-in area potentially for Central Health, as well as the eligibility and financial screening services for both community care and Central Health. And then if you go up the spine, and on the left, at the kind of top edge of the Central Health clinical space would be the diagnostic space. So we're thinking imaging, and John, correct me here, but it's just very simple X-rays and mammography potentially in this area, ultrasound, and that would be operated by Central Health or vendor through Central Health. And then if you go to the north of that, some break rooms and other kind of staff spaces, other support spaces. This is where the loading dock is, and like I think we have some, just security and other things back there as well. And then one more. This is the administrative floor. These are really large floor plates, and so I want you to kind of think about this as two areas. And it could be, it's not assigned yet, so it could be that community care is to the north, Central Health and Sendero is to the south, and in the middle, though, is a row of conference rooms that everyone could use. We have some challenges on this floor with the fire exits being two on the bottom of the stairs and one on the north-hand side with the stairs. We've had some requests from our partner community care, and we're looking at trying to figure out how we can accommodate those, and we can talk a little bit more about that. So this is still very much a floor that's in progress and in motion. Mix of offices, huddle spaces, workbenches, because so many of us are just coming in, landing for a meeting, going into the conference room, don't need a whole office space. And I think it's a really nice space. We haven't done any real exterior renderings or any discussion really around landscape or anything else like that, but we are trying to create as much natural light as possible. There is an atrium, so that kind of hatch-marked rectangle with the kind of diamond shape, inverted diamond shape, is in kind of glass, hopefully trying to get glass to the lower level as well. And so there's a lot of creative ideas to try to do that, potentially glass blocks on the floor. So that is my open session presentation. I'm happy to answer any questions. We are still really hoping on a 2025 construction date. Just keep all those candles, prayers, whatever going.
Manager Martin, you have a question?
You said you're building up X-ray?
That is the design intent at this point.
In light of that, will radiology services be available digitally to interpret stuff for this most?
I'm going to invite my colleague. I like to joke I'm an English major.
It's a lot of money to build out an X-ray space. It's a lot of money.
And we do have X-ray in a couple of other locations, but I think to answer your question, Manager Martin, the professional readings would be done off-site through a contract. And those would be, the results would be electronically received, embedded into the medical record.
Any further? Yes, Manager Valdez.
I know this is an awful, in Spanish, ya después de atole, after the oatmeal or the atole is made. But in light of the climate change and all the things that are happening, I'm wondering whether or not we thought about, if we can think about anything else that we're going to be building or creating or remodeling, whether or not we could create a space like a cooling center or a place that people can go to when a tornado is coming or 150-mile-an-hour winds or supersized hail and or blackouts because they're not going to have any place to go.
So it's a good point. We are planning on a generator for the site, especially given all the clinical services that are going to require that. I think that lower level, if there is a fortress in Austin, it might be this.
That's because when I was growing up in my small town of Mission, the post office building all the post offices had a basement, and that's had the square. This is where you went when the alarm went off, and So I like going back to those old days where you had the major. We got a hurricane coming, or we got a tornado coming, and we have no electricity, and there's going to be a lot of water.
Thank you,
If
Manager
they could
Valdez.
consider that.
Yes,
Thank you.
thank you.
I want to thank you for all the work that we're doing for our patients that still needed services, and now we're going to have an opportunity to receive better services.
Manager Musaitif.
Thank you. Mine is really quick. I noticed something that caught my attention. Hoteling?
I'm sorry, say that again.
Something that said hotels?
Hotel
Hoteling?
space.
Office
So
space.
we have a number of folks, remember we're into this connected work program, and so we work, some of us, nobody in this room, but some of us work, some days in the office 1 day a week, sometimes 2 or 3 days. You don't need a whole office necessarily dedicated to you if you're not gonna be here. The rule that I'm trying to push is 4 days in the office, you can get a dedicated space. If you're not gonna be here, commit to 4 days in the office. And I won't clock in and clock you out, but I'll just, it's like, hey, if you're going to be here, we're going to allocate some space. If you're not, there's a lovely hotel seat for you. I will escort you over there.
Thank you.
It's an office space term, but we are not encouraging staff to stay overnight.
Manager
At their
Jones.
desk working.
Yes, quick questions. One is just, so David Powell will be moving from where it currently is into this.
That is the current plan. We can talk a little bit more about that in closed session and
Okay.
as to the why.
Okay, and then the second question.
Went to the closed session.
All right. I'm going to assume Dr. Bell
I'm happy to answer any questions.
is not responding.
At another point.
Okay, so what we're going to do now is we're going to go into closed session. So today is June the 14th. Oh, sorry. Okay, sorry. I announce that the board is convening in closed Are we on? All right. Managers, let me see. So we are leaving closed session, and again, today is 6/14/23, and it is 8:36 p.m. There was no motion necessary on our information. Item number 3, we're going to put off to a future meeting. Item number 2, you can read it, and that's all it has to say, so there's no motion necessary on that. And then, so we're going to move on to item number 7, confirm the next regular board meeting date, time, and location. Managers, our next Central Health Board of Managers meeting is tentatively scheduled for Wednesday, June 28th, 2023 at 1 p.m. or immediately following the Executive Committee meeting at Central Health Administrative Offices, 1111 East Cesar Chavez Street, Austin, Texas, 78702. At this time, I am ready to accept a motion. Manager Rabez? Yes, and a second? Manager Yeah, Manager McConaughey. Yep. Okay, I apologize, Manager McConaughey. We're all getting kind of tired, yes. So now, vote, please. We need a vote to... Yeah, aye. Okay. And everyone voted, so thank you.